Good afternoon, everyone. Actually, nuclear medicine has a notorious reputation of being called unclear medicine. Just the play of words, play of letters. I hope I'll keep it simple. Let us start with an analogy. We know that United States and Cuba are arch enemies. Suppose if United States wanted to find out what is happening in Cuba, what would it do? It would just send a secret mission, start a secret mission there. So for a successful secret mission, what would it do? It will send spies who look very similar, who speak these languages of the Cubans and also look like and behave like Cubans. So they'll usually send Cubans in exile. They wouldn't send a white American there, they'll get caught. Right? So it should be very close to the Cubans. And they'll send only a few agents. If they send a battalion, it becomes a battle. So, and those spies should be loyal to the country, that the US, and should go there, collect information, and send it back to the country. So why am I talking about this? Because nuclear medicine involves usage of what is called a tracer, which is nothing but a tracking molecule, which is like an investigation agent. It goes and finds out what is happening inside the patient's body. Suppose we know that there is a problem, or if we want to find out what is the function of an organ, we have to investigate. So we send some molecules which have characteristics similar to the spice. So that should either be an endogenous substance or a substance which follows the physiological or the biochemical or the pathological process. That is the first thing. It should be given in a very minute amount. Giving large amounts will elicit a pharmacological response, and should not get disintegrated inside the body because of biological processes, and it should send signals with which we'll find out what is happening inside the body. That could be either gamma rays or a positron emitter. It could be any of that. So basically, tracer is a radiopharmaceutical. Already been told it contains radioactive material, either gamma or positron. Gamma is gamma camera, positron PET. So what kind of pharmaceutical we'll use depends upon the diagnostic question. The same radiopharmaceutical, when administered in a different route or a different means, may behave differently. So all these things is what matters. So I'll just give some examples in thoracic imaging. Not everything can be covered in this 10 minutes. I'll just give you some examples. So for example, if you want to find out how the ventilation of lungs is, like how is the air flowing in and out of the lungs. So basically, we want to find out how the air flow. So we have to label air, right? So we have some radioactive gases like krypton-81M and xenon-133. So these can be inhaled by the patient, and once inside the lungs, they'll distribute proportional to the airflow and will send out signals, gamma rays, which can be imaged. The problem is, gases once flow in, they also come out. So it has to be imaged very quickly, and it's very difficult to handle gases. So an alternative is to use aerosols. Aerosols is nothing but like a liquid is vaporized into small tiny particles, moisture particles, which float in the air. So this again can be inhaled by the patient, and proportional to the airflow in both the lungs and different parts of the lungs, these aerosols will go and deposit in the alveoli. So commonly we use a technetium-9M DTPA aerosol, like nebulized and inhaled by the patient. Once inhaled, it will distribute in the bilateral lungs. So once it goes inside, it goes to bilateral trachea and it diffuses. So what we see on the right side is that particular image. It looks hazy, but that's how most of the nuclear medicine images are. If you see, the larger aerosols have actually deposited in the trachea and in the larger bronchi and the bronchioles. But still you can make out there is a fine distribution of molecules in both the lung fields. So this says that there is no problem in the ventilation either. It is a normal ventilation. And you see there is a large area of photopenia that is basically because of the presence of the heart there. You also see some activity here. This is basically in the stomach, and because the patient swallows the aerosols, it goes into the stomach also. Okay, this is one example. The other example is what about perfusion of lungs? Perfusion is nothing but blood flow per gram of tissue. So how much blood is flowing per gram of the lung tissue? How to do that? So basically it's about blood. So we have to label blood, right? But also it has to stay in the lungs for us to image. So we use something called macro aggregated albumin, labeled to technetium-99M. These particles are of size larger than the caliber of the capillaries in the pulmonary bed. So once they go, I'll show you. So once we inject into any of the vein, so it goes in the right heart, and goes through the pulmonary artery into bilateral lungs proportional to the blood flow. Suppose if there is no problem, those particles will get trapped in the capillary bed and will send out signals, that is gamma rays, which can be used for imaging, right. So, I will show you a picture. So, this is what we see. We do not see any of, I showed you this, the right heart and all, it is not seen here, because once it goes there, we see only the lungs. Whatever we inject, it goes into the lungs and stays there. It cannot come out of the lungs because of the size of the particles, which are larger than that of the capillary size. So, here again, the distribution is proportional to the blood flow at that point of injection. Okay, again, this area is because of the presence of the heart, and we know that there is some regional disturbance in, differences in the distribution of blood, say based on the position of the patient. So, that will be there. So, these ventilation perfusion images can be compared against each other. Is there any discrepancy in the ventilation, the perfusion using these images? We can do a subtraction imaging also. So, I will give one example where it is used. Say for example, there is a pulmonary embolism, basically a small clot which gets dislodged from somewhere and goes and lodged into one of the arteries or the arterioles. What happens? It blocks the blood flow to that region, so that region dies. Okay. So, that is called pulmonary embolism, and it could be life threatening. So, in that situation, if you inject this macro aggregated albumin, which will distribute based on the blood flow, you will see that there will be an area which is defective, means blood could not flow there. So, this way we can identify. Ideally, in case of acute pulmonary embolism, you will find that ventilation will be normal. Okay, we saw ventilation perfusion of the lungs. Let us skip to perfusion of heart muscles. Again, perfusion means is the blood flow per gram of tissue of the myocardium. Okay. We have heard of this heart attacks and all, very commonly we deal with it. Basically, it is because of the occlusion or the stenosis of the coronary arteries. So, what happens? Blood flow to the region beyond that is reduced. So, this could be a gradual narrowing, which may result in difficulty in a person to do exercise. When person does not exercise, they may have chest pain, that is angina. So, we have to find out if there is any, anything affecting that part of the myocardium. So, for that, we have to use a substance that of course goes along with the blood, proportional to the blood flow, but also is retained in the myocardium. So, maintain the myocardium proportional to the blood flow, so that we can image later. So, some substances you might have heard of thallium-201, which has been used for a very long time, and after that we have MIB, which is commonly used, and PET tracers, ammonia and chloride. So, if you see, this is the like three-dimensional image. So, we acquire specs here, so three-dimensional image here. So, the proportion, the way it is, the tracer is distributed is proportional to the blood flow. So, this is an area where there is less blood flow, and this is normal. And you can see it is proportional. I mean, you can see this is the septal layer, this is anterior apex and the inferior. We usually make into slices. So, this slicing is slightly different. We cut across, say a capsicum, if you have seen, if you have cut capsicum, you make these rings. So, this is the anterior wall, lateral wall, inferior and the septum. Okay. So, if you cut that, you will get slices like this. Is it similar to the capsicum cut here? So, that way we can get multiple slices, we can cut vertically also and also horizontally, and we can get these slices. What do we do with these slices? We can see if there is any difference in the flow at the time of stress and rest. A patient will be asked to exercise, and we will find out we will image first for the blood perfusion during that period and at rest. If there is any difference between stress and rest, that means it is ischemia. If there is no difference, then it is a scar or an infarct. If you can see here, so there is a defect in the stress images. The first row is the stress image, second is the rest image. You can see that there is difference in the stress versus rest. That means at rest it is normal, stress it is reduced. That means it is ischemia. These areas where I have pointed out. And a scar or infarct will not show any improvement in stress versus rest. This way we can identify which is scar or which is an ischemic area. Another one which was discussed before the previous slide is the viability, like which amount of tissue or where there is chronic ischemia, chronic rest ischemia. So, by using what is called like metabolism agent of glucose, fluorodeoxyglucose, these areas which are chronic ischemia will shift to glucose metabolism. That will indicate the viable areas. The last one is the contractile function of the heart using what is called a MUGA. So, normally echocardiography is used. We can use a radionuclide also, where the concentration of the tracer will be proportional to the volume, with which we can mark region of interest, end diastolic, end systolic. This minus this gives the stroke volume upon the total end diastolic counts gives the ejection fraction. Okay. Thank you.